Ambulance-based imaging, or mobile imaging, is an extremely advantageous development in the treatment of a number of conditions. In particular, for patients who suffer a stroke, it can have benefits that impact their entire quality of life. However, as with all technological developments, there are still some hurdles to overcome to ensure this resource is applied and used to reap maximum benefits for sufferers. A stroke can happen in two main ways. A blood clot causes an ischemic stroke, which are dangerous as they block arteries and cut off blood flow, or a hemorrhagic stroke, which is a break in the wall of a blood vessel causing blood to leak into the brain. They both stop the delivery of oxygen and nutrients to the brain. The best way to prevent a stroke is done by living healthily, which means eating a healthy diet, maintaining a healthy weight, exercise regularly, avoid alcohol or moderate consumption, not smoke, and keep blood pressure under control. To help further reduce the risk of strokes, anticoagulant medication may be prescribed. Arterial surgery can also be used to lower the risk of repeat strokes. Both require different forms of treatment. It is not only important that the type of stroke is diagnosed quickly to reduce the damage done to the brain, but also because treatment suitable for one kind of stroke can be harmful to someone who has had a different kind. Treatment can begin with drugs to break down clots and prevent further ones from forming. If the patient is taking anticoagulant medication, they can be given drugs or blood transfusions to counter the medication's effects. The type of diagnostic tests that are used to determine which type of stroke has occurred include blood tests, CT scans, MRI scans, ultrasound, cerebral angiogram, and echocardiogram. The implementation of technologies, mobile CT scanners and MRI units in ambulances is what is offering stroke patients faster diagnosis and treatment.
There are new technological advancements contributing to more efficient and quicker ways to detect, treat, and diagnose stroke in patients. The face-arm speech test is a very quick and simple way used to detect early signs of stroke in a patient. This method is used to identify and examine the early stages of stroke. Paramedics can detect any weaknesses in the face and arm or speech impediments. Paramedics can use simple movements and questions to test the patient for further signs of stroke. These actions are split into three subcategories: facial, arm, and speech. Once a patient has been confirmed to suffer a stroke, the paramedic will then notify the hospital, and then further actions will be done at the hospital.
FAST is an acronym for the Face, Arm, and Speech Test, and knowing how to use it could save a stroke victim's life. First, check for facial weakness. An uneven smile could mean trouble. Next, check for arm weakness. Inability to raise both arms evenly could be another sign. And finally, check for slurred speech. If there are problems, call 911, because the time you save could save you or someone you love. If you suspect stroke, act fast.
A more technological advancement for ambulance-based imaging is to dispatch a portable MRI ambulance once a patient has showed signs of a stroke. This new device, originally created in New Zealand, can determine what type of stroke it is. Once a type of stroke is determined, treatment can be arranged and planned within the time the patient arrives at the hospital. The design of this ambulance is very simple and very similar to an ordinary ambulance. The patient is wheeled on a stretcher and then scanned through the MRI scanner before the patient arrives to the hospital. This is more efficient and effective because by the time the patient gets to the hospital, without the portable MRI ambulance, it may become too late. Mobile stroke units is very similar to the portable MRI ambulance. However, instead of using MRI scanners, CT scanners are used instead. The mobile stroke unit gets dispatched at the same time as an ambulance, and then once it's confirmed that the patient is suffering from a stroke, the patient gets handed over to the mobile stroke unit. This unit includes a CT scanner which can determine the type of stroke the patient is suffering from. The team on board consists of a critical care nurse, paramedic, CT technologist, and an EMS driver, who can do blood tests to further confirm the type of stroke. The team then communicates with a physician. The benefiting factor in regards to a mobile stroke unit is the ability to treat the patient immediately.
Into the vehicle via the telemedicine and see the patient and makes their assessments.
Ma'am, how are you doing? Can you talk to us?
If there's any type of therapy to be administered, we will do it right there at scene.
The TPA is infusing.
We have good evidence now for the use of intravenous TPA, which is the clotbuster medication, and we can use that medication up to 4.5 hours after the onset of a stroke.
We're actually seeing that we're saving 90 minutes of time by bringing everything to the patient.
However, with the advancements detecting and treating stroke victims, a major disadvantage is time. Time is a disadvantage because for the mobile stroke unit, they rely only on a certain period of time from the patient's home to the hospital to treat the patient, which can range from a couple of hours to a couple of minutes. MRI scans can take between 20 to 45 minutes, and a CT scan can take between 20 to 60 minutes. These scans can be finished after a patient has reached a hospital. The scans become rushed and therefore can lead to inaccurate diagnosis.
The main advantage of specialised ambulances with CT scanners is a reduction in the alarm to treatment time. A study conducted from May 2011 to January 2013 in Berlin, Germany, concluded that ambulance-based thrombolysis enabled by ambulance-based imaging techniques reduced alarm to treatment time by 15 minutes. Another study in Germany reported a 38-minute reduction time when compared to the control group of the study. According to the Center for Stroke Research in Berlin, a patient suffering from an acute stroke should be treated at a specialized stroke unit. Alarmingly, the study in Berlin showed that 245 of 2,110 patients with cerebrovascular events were transported to hospitals without a stroke unit when cared for in conventional ambulances. It was also revealed that 43% of control patients with intracranial hemorrhage were delivered to hospitals without a neurosurgery department. Both studies in Germany showed that patients with cerebrovascular events cared for in an ambulance equipped with CT scanners were more frequently delivered to hospitals with stroke units than patients cared for in the conventional emergency system. One study reported that pre-hospital triage in mobile stroke units decreased inadequate delivery of patients with ischemic stroke to a hospital without a stroke unit by more than 50%. The rate of patients with intracranial hemorrhage delivered to a hospital without a neurosurgery department was reduced by more than 60%. Although these ambulances are currently being implemented around the world for ongoing research, there has only been 2 studies published. This is a major limitation of the project because the potential advantages of these mobile stroke units have not yet been weighed against the costs. One study stated that a single mobile stroke unit can cost upwards of $1.4 million. The utilization of these costly mobile units can only be effective if they are accurately deployed to the correct patients. This requires an accurate stroke identification algorithm to be in place at the dispatch level, otherwise the ambulances will either not be used or will be called to a high number of non-stroke patients. The study conducted in Berlin indicated that the combination of accurate delivery of stroke patients to appropriate hospitals and the reduction of alarm to treatment time resulted in a decrease of the magnitude of disability of stroke patients. According to the Stroke Foundation, in 2012 there were over 420,000 people living with the effects of stroke in Australia. Of these, 2/3 sustained disability that impeded their ability to carry out activities of daily living unassisted. It was estimated that the cost of disability caused by stroke in Australia was $5 billion in 2012. Currently, there are no available cost-effective analyses published in regards to specialised mobile stroke units and are currently under investigation.
Only once these investigations and studies have concluded will we know the true cost of imaging techniques used in ambulances. Based on all the research done in regards to stroke patients, the time taken to diagnose and applying the appropriate treatment are key factors in being able to increase quality of life after the event. Hopefully, new technologies and cost-effective applications of diagnosing stroke sufferers can be found and further integrated into ambulances to accomplish this.